All right, everybody, welcome to day 2. My name is Dave Naeger, and I'm a chest radiologist at UCSF. We're going to start off the day with the bread and butter of chest radiology, pulmonary nodules. And the reason I put together this talk is because pulmonary nodules are actually pretty variable. Right? Every one of these is a nodule. And I fear that sometimes we just say, oh, they're non-specific. Could be bad, could be okay. So how can we be helpful? How do we become more specific? The path I'm going to go through is to first, we can find definitely benign features. Then they don't need follow-up. If that's not there, we can give follow-up recommendations as radiologists. And if they're not small enough to fall into our follow-up recommendations, then we can assess how bad is this nodule. Because then as a collaborative team, we can figure out what should be done next. So that's what we're going to go through. Definitely benign features, follow-up of small nodules, and then how we can assess the risk, including PET. So what are our definitely benign features? People usually say 3. I'm going to have 4 here. There's benign calcification, fat, long-term stability. We'll talk about what that means. And then one that I sort of realized is true, small nodules in young people also are benign. So let's go through each one of those. Benign calcifications. Here's the classic one, a totally calcified granuloma. Essentially calcified nodules, usually also from granulomatous disease. Concentric, or the classic popcorn of a hamartoma. And I'll give you a tip that thins can really help here with the small nodules. So for example, on this medium thickness slice, I don't really know if this one's calcified. But on thins, it's pretty clearly calcified on the soft tissue windows there. So what are the other calcifications then? The stippled or small calcifications, that's a indeterminate. Eccentric, very irregular calcifications. And then this last sort of odd category, which is if the calcification is central, and maybe you'd be okay with it, if it's in a really ugly looking nodule, then that ugly looking nodule part trumps. All right, our second benign feature is fat. Here's a nice nodule, soft tissue windows. I have no idea what it is. I'm sorry, in lung windows, but on soft tissue windows, you sort of get a sense that it's fat. We could actually measure it. And as long as it is fat density, that is a benign feature. Next is long-term stability. So the classic definition here is 2 years for solid nodules. The problem, and where everything is in flux right now, is ground glass nodules. We have a whole talk on this together later in the morning, but how long you have to follow these up is not totally clear. It's probably at least 3 years or more. And the reason why they say or more is because late, sometimes these nodules can really get bad. Here's 2 ground glass nodules we saw at our institution, and each exploded into an invasive adenocarcinoma, but at 8 years. So how long do these really need to be followed? Still being worked out. And then the last one that I sort of add is small nodules in young patients. That requires some definition. So small, we'll just say whatever's in the Fleischer Society guidelines, so 8 millimeters or smaller. And then young is defined as my age or younger. I'm joking. I wish that were true, but it's not. So it's 35, and I got that number from the Fleischer Society guidelines. It's actually at the bottom, saying that this does not apply to young people. Okay, so if it is not one of those features, I mean, those are our get out of jail free card, then we can provide follow-up if it's small. That's the next way we're helpful. So the way we do that is with this big table. You've probably all seen this. It's classic. It's now 10 years old this year. And this is our follow-up recommendation table. There's lots and lots of words and lots of numbers. So I can't memorize this. So I have a simplified version, and this I can actually get into my brain. I just think about it in low risk and high risk. So in low risk, 4 millimeters and smaller, no follow-up at all. If you're at a medium-sized nodule and low risk, you just get 1 follow-up at a year. And a large nodule is 2 follow-ups in 2 years, right? So roughly at the 1-year mark. There's actually ranges, but I just find that really hard to memorize. So this is how I do it. And then if it's a high-risk patient, all these recommendations move up 1. Okay? So the smallest nodule now does need to be followed, but it's just the one follow-up at a year. Medium nodules now get the 2 follow-ups in 2 years, so roughly 1 a year. And the biggest nodules now get this 3 CTs in 2 years, and I just memorized that first CT is in the 3 to 6 month range. And then if you look at those guidelines, what does it say we should do if it's over 8 millimeters? It says, okay, well, you have any one of these 4 options. So let's see if I can break them down. How many people are doing dynamic contrast enhanced CT? Nobody. Never done. So this was all the rage 10 years ago, which is why it's in our official recommendations, and nobody does it. And particularly now with concerns over radiation, it's just not going to happen. So we have 3 options. We have the most conservative, which is just follow it like the 7 millimeter nodules. We can do PET, which is still fairly conservative, but has a lot of radiation, is pretty costly. Or we can do something invasive. So we have this range from the same thing we do with a small nodule down to an invasive test. So that's where we can come in, because we can help assess how bad is this nodule, and in consultation with the other doctors and the patient often, then figure out what the best plan is for these bigger nodules. So let's talk about how we can help assess. We'll do it with CT and PET. By CT, the first criteria we'll talk about is size. Now we're concerned about these 8 millimeters and bigger, but still I thought it'd be interesting to say, how risky really are these nodules? You know, we just went through a table talking about following up 4 to 7 millimeters. What is the chance that these things turn out to be cancer? It's like nothing, right? That's what we're doing all this follow. That whole table is about 1%. So that's something I keep in the back of my mind. Risk here pretty low. Once it starts getting bigger though, the risk does actually start going up quite a bit. And you can see the 2 centimeter mark, it's really risky. So what should we be thinking about with these nodules? That middle nodule, it's 1.3 centimeters, it's sort of indeterminate, that turned out to be a squamous. That little tiny dot, we should assume is benign. You know, it'll follow up based on recommendations. Turned out that was actually cancer. There's always exceptions. I'll tell you when there are exceptions, it does tend to be Mets in my experience, the little tiny dots that grow. And then that big, huge one, we should assume that's cancer. Of course, there are exceptions. That one was TB, but that's how we're supposed to be thinking until we're proven wrong. The next feature is growth. And the key here is that slow or moderate continued growth is really concerning. So this is only a 6 millimeter nodule. That is not that concerning, except that 6 months prior, it was smaller. It was still smaller a year prior, 2 years, even tinier. This thing has done nothing but grow. That is now concerning. It turned out to be the smallest adeno you're ever gonna find. Or this one. This is a very scary looking nodule. That is spiculated. I mean, that is screaming cancer. Except 3 months earlier, there was nothing there. That is too fast of a growth to be in the normal range of cancers. I mean, it technically could be, it deserves a follow-up, but this is now less concerning than I thought. We gave them the benefit of the doubt, and it started going away. So it was an infection. I want to talk about with the growth, the opposite, a very slight decrease in size. It turns out that if a nodule gets slightly smaller, that's really helpful, right? It's usually benign. Small decreases transiently do happen with cancer, even if not treated. Okay? So if you have a single follow-up and a slight decrease in size, you can say that that's helpful, suggests it's not malignancy, but still needs follow-up. So let me give you an example. This patient had lots of cysts and emphysema, and that small nodule right there, and then eventually it grew. And that looked, it was over a time course, it looked like cancer. They asked for a biopsy, we said, sure, no problem. Put them in the scanner a couple weeks later, and it got smaller, no treatment. So we canceled the biopsy. That suggests it's not malignancy because it got smaller by itself. But the person needs a follow-up. They got a follow-up, and it continued to grow again. Okay? Then it was finally biopsied, and it was proven to be an adeno the whole time. No treatment. So it happens So you can't let these people fall off the face of the planet, okay? Next characteristic is the border. So spiculation here is, of course, the bad characteristic. If you're spiculated, high chance of being cancer. There's some combination of causing fibrosis or the cancer spreading along the lymphatics. The problem is, as I showed with that big example, granulomatous disease can do it too. But that is a concerning feature. The next is cavitation. So the classic teaching here is cavitation with a really thin wall tends to be benign. So here it's in the 90% chance. Really thick-walled nodules with cavitation tend to be malignant, somewhere in the 80% chance. What that means is there's somewhere in the middle that's not so clear. Okay, so this is the unhelpful thickness of the wall. And I'll tell you, the extremes are even more true. So if you have a tiny, tiny thin wall, like here it's a millimeter, the chance of that being benign is exceedingly high, close to 100%. For example, this one was cocci. In the rare cases that it is actually cancer, it does tend to be gyne cancers, like this uterine. That was a MET, but it's very uncommon to be like that. The next feature is density. This is the classic PIMP question in all of chest radiology. If you have two different patients and they have nodules about the same size and one is solid and one is ground glass, who is more likely to have a neoplastic nodule? What do you think? So it's the ground glass, right? Counterintuitive. So the risk is actually much higher for ground glass. Probably greater than 50%. And the reason is that it's counterintuitive is there's so many more solid pulmonary nodules in the world that the really bad ones that we've seen that turn into cancers tend to be solid. We see more solid ones. In the smaller number of ground glass nodules in the world, though, more of them are these very indolent level adenocarcinomas. And we're going to talk about those later in the morning. So when you see ground glass like this here in a patient with lots of emphysema, the risk of neoplasm is actually surprisingly high. So they cannot be ignored. The good thing is these ones tend to be less aggressive. So these are the ones that won't really show up on PET. They grow slowly, and that's why sometimes we follow them. And the prognosis is not so bad. So these tend not to be the cancers that are horrible and then really destroy people's lives. But they still need to be followed because they're risky. Right? And they're less smoking related. All right, and the last part is how can we use PET to really assess risk? And I noticed as I try to put this together that this is the part of PET reading that I find has tons and tons of artifacts, and that they actually affect how I read the PET for nodule cases. In fact, more than any other use for PET. So I thought we would run through a couple only clinically relevant artifacts that can help us assess PET. So here are the four, but I'm just going to go through them. The first is misregistration. So the CT and the PET are acquired at different times. Here you can see in that person's head, the images don't always overlap, and that's because the person moved their head. Well, fine, who cares about the head? Nothing important up there. We're all about the chest. The problem in the chest is the diaphragm moves as well. So you get lots of misregistration around there. So for example, this patient had a known metastasis in the liver, and in our follow-up PET, we see this. It looks like a pulmonary nodule. So there it is in the chest. We go to find it, and there is no nodule. I even put the overlay. I could not find the nodule. Where is it? Down here in the liver. It's actually another liver met. So misregistration around the diaphragm can happen. It's very common. So what that means is if we actually found the nodule in the liver first, the metabolism is not going to be there. You actually have to look somewhere else, in this case higher, to find out that it was hypermetabolic. What that also means is that nodule, or I'm sorry, that liver metastasis that looks like it's in the dome, that actually was much lower in the liver. It's not even in the dome. So things really can move around in that area and be misregistered. So the take-home point is to look high and low, and it can even fake you out to look like it's in the lung or the liver if it's the opposite. The next artifact that's clinically relevant is attenuation correction errors. So the CT actually has two purposes here. One is so you can actually find the lesions that are glowing on PET, but also it corrects the picture. So what do I mean by that? This is actually what a PET looks like when it comes off the scanner. Lots of activity up here in the head because the salivary glands and the brain, not much blocking the photons. Whereas the pelvis, for example, lots of muscles and bones. Everything's blocked. So you can't really read that. So what does the scanner do? It looks at the CT, figures out how much soft tissue and bone is here and there, et cetera, and then back calculates and says, this must be how much FDD is actually distributed throughout the body. Okay? That is actually the PET scan that's read and you see in packs and is overlaid over CT. So that's fine when things work well. So for example, lesions in the lung and the liver, notice that you can't actually tell much of a difference between those two organs on uncorrected PET. The scanner actually needs to go to the CT and figure out where the lung is, which is low density. Where's the liver, which is high density? And then it corrects that entire region to give you the right answer at the end. And that's fine unless the person's diaphragm moved a lot between the two. Then it's going to correct, assuming that the lung volume is this big or that big. And it can be wrong, and then you'll get the wrong correction. So the take-home point here, and it's, you can sort of play it in your head. It actually takes a couple of minutes to figure out the math. But the summary here is near the diaphragm, the SUVs can be wrong. And if you see misregistration on the PET and the CT of the diaphragm, probably the SUVs are incorrect in that region. The next is motion. This is the same patient, inspiration, expiration, the exact same day. So you can imagine if a nodule is there, that's a lot of motion. And the problem is, on PET, we're actually taking the picture while they're breathing. So if they breathe that much, on PET it's going to create this big blurry hot spot. So the motion, particularly around the diaphragm, will blur out our nodules and then usually make the SUV really low. And then the last sort of artifact I want to talk about was size. So if these 7 nodules, let's say, were inside a patient's lung, when we actually take the PET scan, they start getting bigger and blurrier. And that's fine in the big nodules, right? We can still see how hot the center is. But as the nodule gets smaller and smaller and smaller, it starts getting blurred out. And by the time we get to tiny nodules, we might not even see them. So the take home is PET's not so great with small things. So small lesions tend to be really blurry and the SUV's incorrectly low. Okay, so that was it for the artifacts. So what were they? We know that we should be looking for them. We saw that lots of them really make the measured SUV too low. And then here's the key point, which we'll talk about in a second. Accurately saying that a nodule has low activity is where PET is valuable. Okay, so if it's artifactually low, that's not helpful. If it is for real low, that is when PET helps. So if you don't believe in SUV, you can say that doubt in your report, or sometimes I won't even put the number if I know the number is wrong, then I don't measure it. Okay, so let's say that we now assessed if we can actually trust the measurement. How do we use it? The simple version is hot nodules are more risky. Nodules with no activity are less risky. But of course, it's more complicated, right? So where does the PET not work for nodules? These ground glass nodules almost never are hot. Really indolent cancers like this carcinoid in the airway is not. And finally, nodules that are full of air, they are not going to have much metabolism. There's not enough cells. Okay, how about the flip? When is it incorrectly positive? Usually it's infections, particularly granulomatous infections. And the big problem here is that infections can be screaming hot, which is the same category of metabolism as cancers. Lots of overlap. So here is the secret sauce of using PET for nodules. When do we start calling it positive? And if you look through all the papers, people say, we should compare it to the lung or the mediastinum or this or that. Lots of people actually said we should use a number. 2.5 has actually been published a lot. So where do I call it positive? Well, it's all about where do you want to be in this little seesaw here. Should we have a low threshold for calling it, which means we won't miss cancers, but we're definitely going to start overcalling some? Or do we want to say, no, it needs to be a little bit hotter before I call it positive? That's going to confirm cancer better, but then we're going to start missing cancers that aren't so hypermetabolic. So which side do we want to be on? Here's the thing. We don't need to confirm cancer well. That is what needles are for. What we actually can do to be helpful is to take a nodule that otherwise is going to be biopsied or causes anxiety to a patient or needs to be followed really closely. If we can take that nodule and suggest with certainty or strong suggestion that it's a low-risk nodule, that they can avoid a biopsy, that is how PET is helpful. Okay. And the only way you do that is if you have a really low threshold. So if you're below that low threshold, we're pretty sure this is not an aggressive lesion. So I used, in these cases, anything above background. Okay? And that gives me this test characteristic. So how does it work out? Let's say we have a medium-sized nodule, starts at 40% risk. In a world without PET, what would that get? A needle. Right? So let's say that they decide to do a PET. If it's positive, okay, anything above background, the risk is now higher. What are they going to get, though? The same biopsy they were going to get anyway. But with that kind of threshold, if it is negative, the chance that lesion is now something bad is 2% or less. Okay? That, I think, is a risk most people are comfortable at least following. Okay? No needles, much more reassuring. So this test does work. In fact, it was one of the first approved indications for PET, believe it or not. The thing is, these days with great CTs, it's just not that helpful in all patients. So people do not get PET CTs in all nodules. And in fact, I usually only see them in these sort of troubleshooting cases where the person's at bad surgical risk and they don't know what to do and everyone's hemming and hawing. This helps push one direction or another. People ask, how small can I measure? Because I told you, small nodules are a problem. The simple version, they say, a centimeter. The real answer is, of course, it depends. So if it's a very aggressive tumor, like let's say a melanoma met, and it's in the apex where things don't move, you can see tiny little nodules, they'll glow. But if it's a medium or low aggressive tumor and it's near the base and it's moving, we probably won't even see 1.5 or 2 centimeter nodules with activity. It just all depends on how big, where it is, and how much motion. Okay, so in this quick run through of nodules, we talked about definitely benign features, follow-up of small nodules, and then how to assess bigger nodules if that's where we are. Okay, we have our SAM questions. So you have them in your booklet. SAMs, as you know, for people doing MOC are required.